Good afternoon, everybody. You've joined me, Kevin Stevenson, again on this episode of I Don't Care with, me, Kevin Stevenson. Again, I just have to always thank you, my viewers and listeners. I try to do that fairly often. And every now and then I still get the question, even coming up on 5 years now, where did the I Don't Care name come from? And I've been in healthcare for about 35 years as a healthcare executive. And so it's not that I don't care personally, but trust me, if you were a patient, you would not want me to be providing direct patient care. Having an MBA and having a doctorate in healthcare administration does not give me the capability to diagnose and treat you. So that's why it's called I Don't Care. But I like to bring on guests who do care and who actually do provide direct patient care. And so one of those folks is with me today, Dr. Najib Al-Hallak. And Dr. Al-Hallak is a medical oncologist and co-leader of the gastrointestinal and neuroendocrine oncology multidisciplinary team at the Barbara Ann Karmanos Cancer Institute. Wow, that was a mouthful, Dr. Al-Hallak. Welcome to I Don't Care.
And thanks for having
absolutely. Me. I wanted to talk to you because in a lot of recent news around the cancer diagnosis of Princess Kate Middleton and the increasing diagnoses of younger people with cancer, I understand you feel that it's a lot more important than ever for families and internal medicine physicians to really begin those conversations with younger patients early about cancer screenings, well before now the recommended age. And particularly important is for members of certain racial and ethnic groups to get screened as soon as they're eligible. And depending upon family and biological circumstances, they should actually be eligible to screen much sooner than they think. So, Dr. Al-Hallak, tell our visitors and listeners just a little bit more about you and about Karmanos.
Sure, yeah. So as you stated, I'm a medical oncologist specialized in GI cancers. That stands for gastrointestinal cancers. For example, most commonly, colon cancer, pancreatic cancer, stomach cancer. Also, I am an associate professor in oncology at Wayne State University. So, of course, as you said, Karmanos is our practice site for treating patients with GI cancers. I also do research, as you said. I focus on the gastrointestinal malignancies research. I do clinical trials, starting from the early phases, phase 1, going to phase 2 and 3. And also I do develop new drugs in collaboration with our basic scientists, starting from even before the phase of the patients, from what we call cell lines and animal models, trying to discover some new treatments, targeted therapy, immunotherapy, different new combinations that can work for pancreatic cancer specifically, which is very hard to find new treatments for. In Karmanos, of course, we are an NCI designated cancer center. That means we are designated by the National Cancer Institute to represent the NCI in the country. And there's probably 50 of those centers in the United States collectively. And we, of course, we are in close collaboration with NCI. We receive, of course, the research funding from them, clinical trials to help, of course, patients with cancer to fight it, to find new treatment options, or actually, as we say today, is to find a better screening tools for patients, even before they get cancer.
Okay, very good. And I think with Princess Kate's recent diagnosis, a lot of people, I think a lot of people were really shocked by that because of her young age. People still think of cancer as being a relatively, middle-aged and older adult disease, for the most part. But, anecdotally, we're hearing a lot about a real increase in diagnoses of real serious cancers in younger and younger patients. And so, several academic research studies recently have noted a rise in cancer in young people. Why is that?
I don't think we have the right answer to that yet. Research is still ongoing to identify the causes of these observations, as you said. It is true. It's just funny that today before even the interview, my nurse practitioner told me that we went to school and we learned that cancer is actually the disease of the elderly.
Yeah.
But we're seeing increasing number of patients in their young age. Today we saw 20s.
Yeah.
I don't know exactly the age, but it was an early 20 young female with cancer, with liver cancer. But we're seeing more increasing number of patients in their 30s and 40s. Yesterday, one of my patients for the past 5 years now has been my patient. He's now 38. So he established with me, he was a 33-year-old with a stage 4 colon cancer. So yesterday we're just, trying to find a better treatment option now at this point because his cancer is progressing and I have to shift him to a different treatment. So yes, it is true. We think at least that it is a combination of environmental and behavioral reasons, and of course along with genetics. But as I said before, that I do genetic testing for all those patients, majority of them will not have a direct cause genetically. And that actually what statistics show, that only 30% of those patients you will identify a genetic cause of their cancer, and which means the rest of them, the 70%, are combination of maybe smoking, heavy alcohol use, obesity, lack of exercise, chemicals in the food that they add to preserve the foods, and not just fast food. People think just fast food it's not just fast food. It's just all things that we eat, canned food, anything you prepare your food with that has added chemicals to preserve it. So it's a long list of things that we cannot pinpoint on one, but I think that's majority of those young patients, cancers are seen because of the combination.
Yeah, you really bring up something that I talk about with friends of mine, particularly my age. But you look at, I sound really old what I'm about to say. Kids these days, the kids today are so much larger than they were when 30, 40 years ago. And you can attribute that obviously to, less exercise, less activity or whatever. But so many of my friends also just agree with me that it's the fact that it's the food additives today that are really shifting that. I live in Texas. I played high school football. Football is king here down in the South. And I use the example all the time. Whenever I played football at a very large high school here in North Texas, our two offensive tackles were considered huge at 6'2", 270 pounds. Now, granted, this was 45 years ago. I'm showing my age. But today, they couldn't make the team because they're so small. And it's just amazing, I'm one of those football recruitment nerds that follow, some high school kids. There's kids now in high school, 6'7", 6'8", 6'9", 350, 360. It's amazing. And
you're right.
Yeah, you have to look at what's in our diets. So and
I agree.
And going, of course, got a little bit off topic there, but I'm going to rein it back in. We've got a young lady here in our community, just exactly as you were talking about your patient. She's 35 years old with two young children, was just diagnosed with, liver cancer. The big one, the liver, the colon, and pancreatic, everything else. And it, it's just heartbreaking watching her go through that. So that leads me to something else. I had a very close friend of mine who's closer to my age, so it's a little bit more expected that he contracted cancer. But he recently had the Whipple procedure. Can you explain that? Because I talk to some people and they look at me, and again, we've established I'm not a clinician, so I'd love to have an expert tell my audience a bit about that.
Yes. So Whipple surgery is a huge, large surgery that we prefer to do it for pancreatic cancer and duodenal cancer, sometimes ampullary cancer, biliary cancer if it's in the outside the liver, in the common bile duct. So there is that region of multiple things meeting, the common bile duct meeting with the pancreatic duct and meeting inside the duodenum. That area including, of course, the head of the pancreas. If cancer arises there, again, including pancreatic cancer, biliary cancer, ampullary cancer, duodenal cancer, if it's in that region, the best surgical approach to try to take the cancer out, along with the lymph nodes around it, is to do that Whipple surgery, to remove part of the pancreas, part of the small intestine, that's the duodenal, removing the gallbladder, part of the liver and the biliary system, even part of the stomach. So it's like a whole big chunk of tissues that has to go out in that area in order to say that I've done the curative intent surgery for this cancer. A lot of time, even after that, we'll have to give the patient chemotherapy after this to prevent the cancer from coming back. The idea is to kill the microcells that's left over that the surgeon cannot see during surgery.
Sure. Well, and you know, the first time I heard about that was years ago, and it sounded like even with the Whipple procedure, the lifespan of that patient wasn't great. And now, you know, after having a close friend have that, you know, my gosh, he's doing tremendously well, cancer-free. And so, you know, very, very encouraging for him.
Yes, correct. I would not withhold the surgery for appropriate patients, as you said, with appropriate staging and diagnosis in this location. They should not have a stage 4 to have this procedure. That's, you know, that should be really, you know, stage 1 or 2 or 3. And the surgeon needs to say that the cancer in this area is not wrapping around that artery, where it's impossible to remove that artery. Some surgeons are able to actually rebuild again that artery, even if they resect it. So it's a complicated discussion. Talk about the regular Whipple or the modified Whipple, call it, for those patients. But in appropriate patients, it should happen because, as you said, it is the only way to cure those cancers in this area, including pancreatic cancer, as I told you, duodenal, biliary, and ampullary cancer, if they arise in that circle where Whipple surgery happens.
Thanks for explaining that. You know, I actually almost understand it now, so I appreciate that. So let's go back to our discussion about younger patients in cancer. How can particularly primary care really, what can they do for their patients, their younger patients, to ensure that, you know, that they are paying attention to this?
I think honestly, devoting 5 to 10 minutes of the primary care visits to talk about family history and updating that every year, because really things happen every year for your family members. A cousin, a brother, etc., diagnosed with a new cancer, and then the problem is the doctors used to take this just in the first visit, the family history, and they just, you know, keep it the same for 10 years. May not change it, but really life is changing. So 5 to 10 minutes every year to spend some time with your patient to squeeze his or her brain of who's new in your family members that are diagnosed with cancer now. So we can add that, and then based on that, if you as a physician seeing, well, it looks like there is a pattern, and if you don't know, it's not a big deal. There are specialists for this. There are genetic counselors. We have those at Karmanos, where, you know, they will meet with the patient, they will draw the tree for them, and who is affected by the cancer, and if they see there is a pattern in that tree, they will recommend genetic testing for this patient, which is either a saliva sample, a SPET test, where they will send it for genetic testing, or a blood test where they take white cells from their blood. Of course, they take the whole blood, but then send it out to the testing company. The company will spin it and then take the white cells DNA and analyze that for germline, which is genes, mutations you were born with. Those are not cancer genes already. They are genes you were born with. And then they have a panel of those genes that are linked to cancers. Okay. So again, spending 5-10 minutes to update the family history with patients. If they are close to the screening age, let's take just the colon cancer as an example. The new screening age now is 45, that you have to do a colonoscopy for any patient, anybody, not patient, people, population, age 45. So if I'm a primary care provider and I see my patients yearly, at age 40, I have to start telling them and putting that as a hard stop that, okay, Mr. Smith, you know, you are now 40. Congrats.
I wish I
But at
remembered
age
40, but I'm just saying.
that start putting that hard stop for them that at age 45 we're going to do the colonoscopy to screen for
Yeah.
colon cancer. Take that moment, of course, to ask, is there any patient, any family members, of course, with colon cancer or other related cancers? People don't understand that colon cancer linked sometimes to stomach cancer, linked to a liver cancer. It's very interesting. Even lung cancer can be linked to colon cancer. Same gene. Yep, same gene can produce those cancers. So let's take that moment to say, but then every year until that age, that 2-3 minutes, just a reminder. Okay, you're 41, so 4 more years to go. Okay, and we're gonna
because it takes a good 5 years to get prep for that first colonoscopy.
It takes exactly good 5 years to convince someone to do a colonoscopy. It may not be as difficult for patients for breast cancer screening with the mammogram at age 40. That's usually an easy. The moment you say, oh, you need to do a mammogram for your breast screening, from breast cancer screening, I'm sure that all the women will sign up to it. Given that fear, right, of the woman, of nothing to affect that area. So it's much easier than colonoscopy.
Oh my gosh, yes. But I will tell you, once I finally acquiesced and had my first colonoscopy, it was the best sleep I ever had. So that's what whenever I'm telling friends, hey, you need to have this done, and they're hesitant, say, man, you're going to get a great nap. So enjoy that. So we talked about, colonoscopy. You obviously talked about mammography. What are some other cancer screenings that young people and people going into their 40s really should consider getting if they have that familial predisposition?
Okay, familial predisposition means they have to start early, right? Really, like in their 20s, if there is that. But let's say about the average population without really strong family history, no genetic predisposition for cancers. The usual ages: colon cancer, we mentioned 45, breast cancer, age 40, prostate cancer. Prostate cancer has 2 ages. The regular age for regular patients are 50. But if they have high risk for prostate cancer, like if they are African American or if they have a close family members with prostate cancer before age 55, they should start screening or at least discussing that with their provider at age 45. So pretty much most of the cancers will start at age 40, breast cancer, colon cancer 45, prostate cancer 45 to 50. Cervical cancer is the youngest, of course, at age 21. They start with that, even if they don't have any predisposition as far as genetic. Lung cancer is the one that is still in the late, and as you know, lung cancer is connected to cigarette smoking and tobacco. So that's the age 50 when they start having the annual, we call it low-dose CT scan for their lungs. They have to meet certain criteria to be eligible for the screening. Of course, they have to be smokers or smoked for about a pack a day for 20 years. But if they smoke, 2 packs a day, then it's going to be shorter than that. So we go by what we call a 20-pack a year. That's like the sentence that we use. That in the doctor world, we know that means a pack a day for 20 years, or 2 packs a day for 10 years. If they had that exposure, they should really be screened for lung cancer with an annual low-dose CT scan.
Well, I know here locally, we have oncology services here at my hospital in Central Texas, and we did a lung cancer screening event for first responders and had low-dose CT because we found, in our research here, we found a high propensity for first responders, particularly firemen, that had inhaled smoke for many, many years. And so, that was a very successful event for us. We actually did identify a couple of people who were, I think they were fortunately both stage 1, but we were able to catch that for them.
Nice. But this is the idea of doing screening. Either catch it in a early stage, like as you said, lung cancer, breast cancer with the mammogram, you catch it at an early stage, cervical cancer. It's interesting. Colon screening with the colonoscopy will catch it before even it becomes a cancer. By removing those polyps, right, you're actually preventing even a predisposition for a cancer by removing those. It is by far the only tool that we have for screening that prevent cancer, not just catch it early, but also prevent cancer from
another screening that I think, and particularly, those of us down here in the South that, like to spend a lot of time outside, spend time on the beach, on the golf course, whatever, skin cancers. That's something that,
Yes.
I don't know that we do a good enough job here as far as skin cancer screenings, because it seems like every day one of my friends is having something taken off of somewhere because they spent so much time outside. What do you suggest in and around skin cancers?
Yes, I suggest at least a visit with your primary care, and if they have any suspicious lesion, to send you to dermatologists as early as possible, because it might not be cancer, but it could be, as you say, the basal cell or squamous cell, or what we don't like to see, of course, the melanoma. That is the most dangerous skin cancer that they see, and they may not know, right? They may examine your back, for example, and just see something and say it looks benign. But I would say be sure and just see a dermatologist. And then after that, once you establish dermatologist, have an annual visit with them like you have with your primary care. It is truly like any other screening tool. It can prevent cancer in the future, and with just a simple skin exam, like as simple as just taking off your clothes, let the dermatologist look at it carefully, identify some lesions, maybe take one out, and you're good for that.
Okay, very good. Well, one thing that I mentioned in your intro, you're talking about screenings are especially important for certain racial and ethnic groups. Why is that?
Correct.
And let's talk a little bit about that.
Yes, it's interesting talk. So statistics showed that African American at a 20% increased risk for cancers in general than the other population. And not only that, it is even in the earlier age, and the risk of dying from cancer is 40% more than the other.
Didn't realize
exactly. That. So it's very interesting numbers. It's not just like 1 or 2% increase. It is a significant increase in this population, and hence that's why when I talked about the prostate cancer, I said African American is one of those risk factors that you want to screen them even earlier than 50 when you have that. Not that I know the reason, of course, behind the increased risk for this genetic, maybe call it predisposition for cancers, but it's interesting enough that we really need to pay attention to it as physicians when we see them and counsel them.
Very good. Well, in our last couple of minutes, Dr. Hallak, any other words that you'd like to share with my audience? Yes,
of course. I'd like that moment here to tell everyone that not to be scared if you are in your 30s and 40s or maybe 20s, that now after you listen to me, you said, oh my God, I have cancer. It's not, I'm saying that. The message that I want to deliver here is that have just a visit with your primary care and go over your family history, your concerns, your exposure, maybe you're concerned about an exposure. And if the primary care, has the answer for you, great. If they don't, there is specialists for that you need to visit. Again, if it's about family history, genetic counselors needs to be visited so they can actually go over your family history and draw the tree for you and maybe do the genetic testing for you. And of course, I'd like to tell the young population, stay away from those environmental and behavioral carcinogenics. And as easy as the smoking. I mean, smoking really is not acceptable. You cannot say I'm smoking only one cigarette a day or more or less. Truly unacceptable. Alcohol, of course, intake. Studies showed that the heavy alcohol intake is strongly correlated with cancers, including GI cancers. So we need to moderate that, minimize the exposure to alcohol as well. And then, of course, as you said, modify our lifestyle. Exercise and lose weight if your doctor, of course, thinks that you are above the average BMI. Work on losing weight. It's really not hard to lose weight if you think about that future that ahead of you, preventing cancer, raising family, be available for your society, of course, to be a productive person. Dr.
Hallak, it's been a pleasure having you on. I really enjoyed this. What a pertinent topic right now. And so thank you for joining me here on I Don't Care.
Thank you, Kevin, for having me. And
absolutely. Dr. Najib Al-Hallak with the Karmanos Cancer Institute. Well, folks, I hope you've learned something. I hope you thought about, making sure that you get your appropriate screenings. If you do have genetic predispositions or other potential risk factors, go get those screenings, talk to your primary care physician, get those scheduled earlier. It may just save your life. So with that, we've wrapped up another episode here of I Don't Care with me, Kevin Stevenson. Look forward to seeing you again next time. Take care.